testing for rotator cuff tendinopathy, and this is going to be tolerance testing and working through a battery of tests to be able to find our starting point for how we're going to manage and put a rehabilitation program together for a tendinopathy in the shoulder. And we're going to be able to draw upon our orthopedic test for this, which is going to be our Hawkins-Kennedy. It's going to be our painful arc, either full or empty can. And what that's going to tell us is not the tissue that's involved, clearly shown with pretty robust research. Jeremy Lewis talks a lot about this, that these positions aren't specific for tissue differentiation, but they do tell us how that hurts there. They do tell us the range of movement that is provocative for our onset of shoulder pain. And that's really important to be able to know and record that at the start, because we're going to be using that test that is provocative as a marker for progression further down the line. We do have some more specific strength testing, so resisted external rotation in this position or in this position and flexion are going to give us indicators of a tissue issue with the external rotators, which is going to come with a rotator cuff tendinopathy. And we're going to want to load manage those. And it's important to be able to draw upon the research here on rotator cuff tendinopathy, or probably more accurately subacromial impingement, subacromial pain, in the recent BMJ recommendation on how we manage that. This information I've got up there, they drew upon 2 systematic reviews, meta-analyses and Cochrane review, concluding that with high certainty, and that's unusual in research, to be able to conclude with high certainty that people who undergo surgery for subacromial pain syndrome, they do get benefits often, but with high certainty we can't say that the benefits are anything superior to what we do with sham surgery or with rehabilitation. And that's really important, because that message gives us the confidence in communicating a conservative approach with our patients, has a really good prognosis for them being able to return to work, being able to return to play. But what seems to be really important in why people benefit from surgery is the enforced relative rest for 6 to 12 weeks. Jeremy Lewis, who we're going to be using as our framework for how we go about this, talks about treating rotator cuff tendinopathy like we would a fracture. So being able to have that enforced rest from provocative movements for 6 to 12 weeks. So we load manage those provocative movements, which are going to be flexion, abduction, so basically elevation and external rotation. But some people are going to turn to us and they're going to say, I'm a painter, I'm a hairdresser, I'm an air hostess, I have to be able to go overhead, I can't do my job without it. So that's where we're going to want to be able to identify, and that's what we use. We're going to use something called the shoulder stability modification procedure. We've got a form to be able to follow it, and the first thing is to identify meaningful activities that the patient is going to tell us are important to them. If I'm a painter and I need to be able to paint up here, then this would be the important movement that I'm going to be able to put through the SSMP. Okay? Can we identify a couple of different ones? Maybe could be a sport, and then we're going to use a systematic procedure of movements to see if we can simply modify the symptoms in going into their provocative position. Okay, we're not going to go through the entire shoulder symptom modification procedure. We're going to just get to the point that we can find something that helps. So then while we're load managing the movements that are painful, overhead and external rotation, we're going to use and find a way of modifying that movement that they have to do. Okay, so it could be as simple as the first one, which is thoracic flexion and extension. So on the painful movement, which we're going to say is this, you're going to do it in thoracic flexion. Do the movement, does it change it? No. Do the movement in extension, so cue the chest up. Oh, yes, I can get higher before I have any problems. That then becomes and helps inform how we would help someone load modify that movement through the course of rehabilitation. When you're going to be painting, extend your thoracic spine whilst dropping this position. Some athletic tape is something that we could use if that was a skill set that we had, but that's not what we're going to be coaching. Being able to use, we found through this SSMP that this maneuver helps for this person and we don't need to do the rest. It would also open up some options for working on thoracic extension, either through movement or mobility as part of rehabilitation. The next part is the starting position of the scapula, and that's where being familiar with all of the ranges of movement from elevation all the way through to posterior tilt of the shoulder blade is important. We've got a video to be able to explain those, but for example, we would do the same provocative movement in elevation to start with, and then see if that helps. Maybe we're going to try depression, so depression of the shoulder blade all the way throughout, then try the movement. And that is something that we can play around with, combinations of any and all of those. So that when you're going to go into this activity, you're going to go into retraction and depression. And then that's something that we're going to be cueing someone to be able to work on whilst they're going to be doing the movement that is provocative. Also useful if we find that retraction, for example, helps, it could inform and guide that we prescribe some retraction-based scapular rehabilitation exercises. And I've got some videos and some ideas around that with bodyweight and with some more gym-based activities. The next one, if this hasn't helped, would be to go through playing with the humeral head. And if you look at Jeremy Lewis's paper, and I'll make a couple of videos, this is going to be done either by the clinician or by a band that someone could do on themselves. So you would try the maneuver, and you would have either a person pressing down into depression of the humeral head whilst we go into the movement. Then maybe elevation, then maybe depression, elevation, an anterior glide or a posterior glide, and we would work through those. You'll also notice that doing the movement with some simultaneous external rotation, so holding a band here and working through, would be another thing that we could try and see if that helps with symptom modification. Working all the way down, if none of this helps, to neuromodulation, where we're going to use some manual therapy, hands-on manual work, so pressing into the tissues and massaging maybe whilst we go through to see if that neuromodulates change the input into the shoulder to help change the pain in the provocative position. Okay, so this is how we're going to help apply and inform symptom modification whilst we're load managing the provocative positions. We've got our orthopedic tests, that are tolerance tests, as markers that we're going to do and repeat over time, because once the system can calm down, and then we can get overhead, and then we can tolerate external rotation, we can then start a graduated load management program towards flexion and external rotation.